we are going to move on to our next panel. And let's see, I don't know if we can change the screen now. There we go. All right, I am really excited about the next panel and to invite all of our panelists to now be promoted to the panel so that they can all see what the questions that you all have. Dr. Khabele is actually the professor and chair of the Department of OBGYN at Washington University in St. Louis and has been for, I think, over 2 years now. She's going to be giving a talk on endometrial cancer disparities. Dr. Khabele is also a member of our Any Mountain expedition team, one of our researchers, and she has been to our last live conference here in 2020 up to Alaska. I'm really grateful that she'll be presenting, so let's go ahead and move into her talk.
Hello, everyone. Thank you so much for giving me the opportunity to talk about endometrial cancer disparities. My name is Dineo Khabele. I'm a professor and chair of the Department of OBGYN at Washington University School of Medicine in St. Louis. I'm delighted to be invited back to speak again at the Let Every Woman Know GYN Cancer Education course. Here are my disclosures, and the opinions expressed here are my own. Uterine or endometrial cancer is a cancer of the womb or the lining of the womb. The American Cancer Society estimates approximately 66,000 cases and 12,500 deaths from uterine cancer in 2022. The newer numbers for 2023 have come, and the overall incidence has increased. And actually, from 2009 to 2018, the incidence of endometrial cancer has increased approximately 2% per year. And we'll come back to this point, but postmenopausal bleeding is the most common symptom. Again, it's the most common gynecologic cancer in the United States, with the incidence that keeps on rising. And it accounts for about 3.6% of all new cancer cases in the United States. The median age is 62 years, but what we're seeing is that this age is, the age of onset is becoming younger and younger. It is the only major cancer with rising incidence and mortality in the United States. So the new cases are seen in this graph here. Years are on the bottom, and then the number of cases per 100,000 women is increasing, and the number of people dying from endometrial cancer is increasing as well at an alarming rate. Uterine cancer has the highest racial disparity in the United States. If we look at incidence by race and ethnicity, the incidence hovers around 26 per 100,000. But then we look at mortality by race and ethnicity, and Black women have are 2 times more likely to die from endometrial cancer than others. And this is really depicted in this picture here, where it's rate per 100,000 women. And Black women are up here at the top, and this is hysterectomy corrected rates of non-endometrioid uterine cancer, the most aggressive type of endometrial cancer. And this is compared to non-Hispanic white and non-Hispanic Asian Pacific Islander and non-Hispanic and Hispanic patients here. So the signs and symptoms of endometrial cancer are postmenopausal bleeding, abnormal vaginal bleeding after menopause, after sex, between periods or periods that are heavier or longer than normal, and vaginal discharge that may be discolored because it perhaps contains blood. Pelvic pain could be a symptom, or difficulty with bowel movements and bladder function, and abdominal swelling. Unfortunately, there are no screening tools for endometrial cancer, but we do have some tools for diagnosis. There are 2 major broad types of endometrial cancer. And this is really simplifying things. And I'll talk about the more nuanced categories of endometrial cancer in a moment. But in general, endometrial cancer is classified into type 1, endometrioid, it looks like the lining of the uterus, and low grade. It's the most common type, more than 80%. It's associated with obesity and estrogen exposure. It's associated with perimenopausal age, frequent estrogen receptor and progesterone receptors in the tissue, positivity. Overall, typically has a favorable prognosis, and early stage at presentation contributes to this favorable prognosis. Has a precursor where the lining of the uterus is thickened, and it's called hyperplasia or endometrial interepithelial neoplasia. And the histology, what it looks like under the microscope, is depicted in the upper right panel. The other type of classification is non-endometrioid. So these tumors don't look like the lining, the endometrial lining of the uterus, and they sometimes look like the ovary. They're serous, and this is a picture here of serous uterine cancer, clear cell or carcinosarcoma. And these are all high grade. The cells look very abnormal, and the grade just lets us know how abnormal the cells look under the microscope and how they are more likely to be more aggressive and spread. This type of cancer is less common, less than 20%. It is not associated with obesity or with estrogen exposure. It is associated with postmenopausal age. It has a poor prognosis and later stage of presentation. Those things are tied. And again, because these cells don't look like the lining of the uterus and are not associated with an overgrowth of the lining of the uterus, they're associated with a thin lining or endometrial atrophy, a common when the lining gets thinned after menopause. And it's disproportionately diagnosed in Black and African American women, with the precursor as endometrial intraepithelial carcinoma. The Cancer Genome Atlas molecular classification is what makes this classification much more nuanced than those typical type 1 or type 2, as I just mentioned. And what we know from looking at the tumor's molecular status, the features that are beyond just looking under the microscope, now you're looking at whether they have ultramutations in a gene called POLE, whether they have microsatellite instability and are hypermutated, which is common with Lynch syndrome or hereditary colon and endometrial cancers, whether they are copy number low, meaning that they have normal copies of the gene, and these are typically the low-grade endometrioid, more favorable prognosis tumors. And then the copy number high, too many copies of the gene and very aggressive tumors are more like ovarian cancer and serous-like. In addition, these tumors can be classified into hot tumors and cold tumors based on their predicted response to immunotherapies. So if we look at prognosis in these molecular classifications, different from that type 1 and type 2, those tumors that have ultramutated POLE in the light blue over here, the progression-free survival, as you see in the y-axis, and the months of survival is in the x-axis. POLE mutated tumors, ultramutated tumors have significantly better prognosis, are associated with better progression-free survival. And then the worst survival is associated with serous-like, copy number high, those tumors that look more closely related to ovarian cancer. And then in between, you have the MSI hypermutated and the low copy number. If you look at overall survival, these were this was an analysis performed on a clinical trial GOG 210, endometrioid only. So these didn't have that histology as I described of the class type 1 and type 2 tumors. These all had under the microscope looked like they were endometrioid. However, when you looked at the molecular classification, the hypermutated again had exceptional prognosis, really did well. And then those that had the copy number altered really behaved similar to the serous cancers and were much more aggressive. And then similarly in between, you have the microsatellite instability deficient and the copy number stable. So I'll switch gears a little bit related to diagnosis because there are disparities in the diagnosis of endometrial cancer by ultrasound. So again, there are no screening tests, but once a person has postmenopausal bleeding, they undergo additional workup. Dr. Kemi Dahl published last year in JAMA Oncology a really nice paper looking at simulated data of transvaginal ultrasound measurement of the endometrial thickness. So this is a side view of the uterus. The lining is the endometrium, and a transvaginal probe is used to measure the thickness. And if the endometrial thickness is less than 4 millimeters in a patient who has postmenopausal bleeding, that was typically supposed to be associated with a low risk of cancer. But what Dr. Dahl and her team showed that in simulated data, if we use this cutoff of 4 millimeters, then this screening, this diagnostic test missed almost 5 times more cases of endometrial cancer amongst Black women versus white women, owing to the greater prevalence of fibroids and non-endometrioid histological type in Black women. And so this performance of this test was not there was a huge discrepancy and difference and disparity in this test when it was applied to Black women. There are also disparities in molecular profiles. Tumors from 105 Black women and 143 white women were included in this very large study where patient samples were taken from multiple institutions and were analyzed by a molecular testing company. And when the study was completed, we were able to look at histology as was reported to the company, and then the molecular profiles. And what the major disparity was that the more aggressive types, serous histology and carcinosarcoma, was more common among Black patients, and then the more favorable prognosis of endometrioid was less common. And so the distinct molecular profiles were driven primarily by the more aggressive histological subtypes seen among Black women. So overall, advances in cancer care have improved outcomes for patients who are diagnosed with endometrial cancer. If we can apply proper prevention and risk reduction, including patients who have hereditary endometrial cancer like Lynch syndrome, so that perhaps they can undergo hysterectomy before they develop cancer. We know that if we can apply diagnostic tools properly, especially telling people about the symptoms of endometrial cancer, then we can perform diagnostic tests, biopsies earlier, sooner than later. There have been multiple advances in treatment and survivorship, and all the way to comfort care and palliative care and to end-of-life care. And there's good evidence-based approaches for each of these steps. And evidence suggests that equal care leads to equal outcomes for Black women, but I've just shown you 2 examples where there remain disparities. And in fact, Black women have lower chances of surviving the 3 most common gynecologic cancers: cervix, which is the most preventable; uterus, which is the most common and becoming the most deadly; and ovarian, which is currently still the most deadly. cancer. So 20 years ago, there was a report from the National Academies of Confronting Racial and Ethnic Disparities in Healthcare. And I always talk about the fact that there's a difference between the differences in care that are due to clinical appropriateness and patient preference and availability of the access to care, which is down here. And then you go down to discrimination, bias, and stereotyping. And the disparities really are what we're talking about when we want to address better access and address health equity, is overcoming the disparity. And differences are okay. But it's the disparity that really contributes to the poor outcomes. And that involves the ecology of healthcare systems, patient access to care, insurance, environmental factors. And then in addition, there's discrimination, biases, stereotyping, uncertainty, and then broader things related to more systemic racism. But if we talk about just on an individual level, there are physician and clinician health stereotypes. And the stereotype is that all pelvic masses in a Black woman is a fibroid. And, fibroids are very common among Black women and make that endometrial thickness diagnostic test a challenge. But not every pelvic mass in a Black woman is a fibroid, and it could be an ovarian cancer or it could be an endometrial cancer that needs further workup if that transvaginal ultrasound is inconclusive and the patient still has postmenopausal bleeding. There's a stereotype of a myth that cancer mutations are not common in Black women. There are hereditary cancers like breast and ovarian cancer and Lynch syndrome. And these hereditary cancers occur across all populations. So there needs to be more awareness and education regarding hereditary cancers amongst physicians and clinicians themselves so that they can better educate their patients. And then Black women, a stereotype that Black women are not willing to undergo treatment, I think is a cultural stereotype that becomes problematic if the clinician or physician is not educated about underlying reasons why. And then they can be better informed in educating about the importance of treatment and cancer survival. From a patient standpoint, there are many patient health stereotypes that sometimes are cultural, sometimes religious. There are stereotypes that a patient may feel that when air hits it, it will spread and they'd be reluctant to undergo surgery. And I think from a physician standpoint, it's important to acknowledge lore, the street doctors, and that how important people in people's communities are about certain beliefs. But at the same time, educate communities about the importance of survival, especially if a cancer is detected early, in improving cancer survival. There is a stereotype or myth that cancer is a death sentence. And I think it's really important to emphasize to communities that there have been advances in treatment and in cancer care, and that that is not necessarily the case. And in fact, for endometrial cancer, if it's diagnosed early, there's a greater than 90% survival, especially with the more favorable types. There's a stereotype that my faith alone will heal me, or I won't claim it, so I don't want to talk about it. And this occurs in many cultures. And I think that it is incumbent upon us in healthcare systems to work with faith-based communities to increase awareness about cancer, and then have partners with faith-based leaders to really work with individual patients. And then finally, this is a big one, that patients really express beliefs that they don't trust doctors, and I don't want to be a guinea pig, and that is a that's a very common that's a very common feeling that many communities have. And I think that we have to do even more work as physicians and healthcare providers to increase trust and to become trustworthy in making sure that we are trusted partners in care. And so, how do you create trustworthy cancer care? It's important to improve outcomes, to have trusted therapeutic partnerships between patients, families, and their communities, and physicians, clinicians, and healthcare systems. And you have to earn and gain trust. And I think that it's important to work together in this. And I see I have this as equal partners, and that's really, really important. So back to Dr. Kemi Dahl, who partnered with patient survivors to create ICANA, the Endometrial Cancer Action Network for African Americans. And I really love this quote from Margie, who's on the steering group. Make sure you find your peace with your doctor. So I was really excited to work behind the scenes on this social media campaign to raise awareness about endometrial cancer. This is a partnership between GlaxoSmithKline, which is a big pharmaceutical company, and they donated the funds to partner with ICANA, with SGO and Move for Her, and then really importantly partnered with the National Pan-Hellenic Council, which represents the Divine Nine, the 9 fraternities and sororities, Black fraternities, sororities in the United States. And this campaign is being amplified by the Divine Nine, and the content was provided by SGO and ICANA. And there are multiple videos, but we're really excited to launch this. And basically, the campaign is about abnormal bleeding. If you see a red dab, it's a red flag. Red dab, red flag. And it's a very simple campaign, and there's a barcode that can be scanned, and there are multiple videos. And there's one from Sean Smith, who's a 59-year-old survivor speaking up about endometrial cancer among Black women. I won't play the video here, but you can scan the barcode, and she tells a part of her story in her own words. There are other videos connected to this campaign from patient family and from Dr. Dahl herself. And so this is one way we can become trustworthy partners. And so with that, I'd like to thank you all for your time.